Hello and welcome. I'm John McAleavey, and at this point, I usually introduce my co-hosts, Barry Munro and Sasha Rabchevsky, and tell you that this is the Three Men and an SCI podcast, and that between us, we have about 110 or 115 years in this spinal cord injured world. But today, I feel as if we're adding the fourth Beatle to the program. We're going to call ourselves Four Men and an SCI because we're thrilled to have the esteemed Dr. Trevor Dyson Hudson join us today. Dr. Trevor's been a good friend of mine for a number of years now, and he has a wealth of information and knowledge that he wanted to come on and share with a couple of old hands. And so, Trevor, welcome to the show. And why don't you tell us a little bit about yourself?
Sure. Thanks so much, John. I'm really honored to be here with you, Barry, and Sasha. And I guess that makes me Ringo, huh? Well,
Yes,
we'll
you are.
try to keep the
Mhm.
beat, so to speak. So, yeah. So, my name's Trevor Dyson Hudson. I'm director of the Center for Spinal Cord Injury Research, which is at Kessler Foundation in West Orange, New Jersey. I'm also co-director of our Neidler-funded spinal cord injury model system of care. And that's perhaps one of the things I'm most proud of because of my own lived experience with spinal cord injury since 1992. So it's going on 34 years. And how much I benefited from at that time being cared for by a spinal cord injury model system and how they've helped me over the years to keep doing what I do.
Sure, sure. And so, again, welcome, and we really look forward to your insights into to today's discussion. And speaking of which, we've kind of kicked around a whole bunch of different ideas, and we have some really good things that we're going to tee up. And I figure, why don't we get started? I'll hand the baton off to Sasha, and he's going to take us into our first segment.
Thank you. It's good to see you, gentlemen. Be on the air with you. I think that for those who are listening for the first time, what we're going to do is we've all shared, as been alluded to, a lot of time on Earth in chairs with paralysis, and so we're going to stemming from our collective experiences in the medical field uh, and recent hospitalizations that show clear evidence. There's an alarming lack of knowledge of spinal cord injury related secondary complications among physicians and other medical professionals. Um, Now, full stop. Hopefully, people are listening. This is dangerous. Now, I don't want to come across as a curmudgeon or old person that's trying to scare the youth. What is dangerous about this is that these conditions that we're talking about are secondary complications that are often not recognized or even anticipated. That doctors, even spinal cord injury specialists, sometimes are not prepared to yield or to do it. So this is, yes, it is an alarm sounding coming from us, but quite frankly, we're a little scared ourselves. So just about the lay of the land now with regard to length of rehabilitation and how short a time we have, and then once you're released, then what? And so, having said that, I thought maybe that's exactly why Trevor has been invited with us, because he can perhaps share some of his recent events that have happened, as well as I can certainly, and Barry and John also contribute. We'd like to get your perspectives, Trevor, on some of the things that you faced challenged in the medical system, and some things that doctors don't really know that we thought we did,
Sure.
that they did.
Sure, sure. So thanks, Sasha. No, I mean, I think, so I will say, I consider myself fortunate in that for the most part of over the last 30 years, I've been relatively healthy. My biggest challenge has been battling pressure injuries. That's an ongoing thing, but I've been trying to nip them in the bud earlier.
Mhm.
All changed about 2 years ago. Um, and so with this experience, I really, this experience and just what I can share with others from it. So at that time, this was spring of 2024. So I was battling a UTI. And at the time, I was drinking lots of water. However, I was getting sicker and sicker. And after a few days, it was clear that I was in trouble. So I finally gave in, and unfortunately, and called 911 early in the morning hours. That's when you do it. So, there's a cautionary tale. Don't wait until, be proactive. If you're feeling
Yeah.
sick, act accordingly.
Mm.
So the trouble was at that point, I was very confused. I couldn't even remember simple things. remember calling 911, giving them the wrong address. I was
Oh, wow.
using like my addresses, combining them. So, by the time they got there, they were obviously very frustrated with me. So that's not a good way to start. I couldn't remember my emergency contact numbers,
Oh,
couldn't remember
wow.
my meds, so I have all these backup meds. So they're like looking and it's like, is it this one? Is it this one? So, they took me to the nearby hospital, emergency department here in New York City, and so in my mind, in the past, I was always counting on myself to advocate, to communicate. I'm a physician, so I'm part of the tribe. I can speak the language. And so, I can communicate. But what happens when you can't do that for yourself? And even with my girlfriend, it was very scary for her because I told her I was called 911 and then she never heard from me again for like a day. You know,
Jeez.
so she was of course scared, because I disappeared into the system. So
Mm.
so I was in the emergency department. They diagnosed me with a urinary tract infection. They also noticed I had a really low sodium. So that was contributing to the confusion. Um, and it's probably because I was drinking a lot of water, all these things contributing to it. And so but they also diagnosed me with, at that time, acute kidney injury. So, they were focused on treating me and the emergent things, but they didn't take into account my spinal cord injury. So, at that time I'm on baclofen, high dose baclofen, and because of my kidney issues, they stopped the baclofen cold turkey.
Ugh.
For anybody, that's something
Wow.
you're not
Yeah.
supposed to do with baclofen. It's supposed to
Ugh.
be tapered. So, luckily for me, I mean, at first I was improving. I was feeling good because I had enough baclofen in my system to kind of hold me over as I was improving. But then slowly I started acting a little weird. I'd be having conversations with my girlfriend and just suddenly out of the blue, be paranoid thoughts. I'm going to be arrested.
Wow.
Just these really, and there's something called baclofen delirium or withdrawal delirium,
Oh,
Wow.
experiencing
wow.
that.
I didn't know that.
And
I've never
so,
heard of that.
yeah, so I was experiencing that delirium, which
Jeez.
then made it even more challenging to care for me because I became combative. They
Mm.
had to restrain me, so I'm in bed restrained.
Trevor, can I interrupt you for 1 second? Were you aware that they were weaning that you weren't getting the
I
baclofen?
did
You
not know. No, yeah, I just,
okay?
so because I was in and out.
Of
Yeah.
course.
Oh,
You
and
can't track all that. Yeah.
yeah, but I had some very, I work at Kessler, so I have some very knowledgeable people. So I mean, thanks to Dr. Kirschbaum, he was able to track what hospital I was admitted to. So, because the warnings went out, and so, you know, uh, a colleague at work reached out to Dr. Kirschbaum. He made calls, to try to find me. HIPAA prevented them from acknowledging it, but when they said we can't comment to that, it kind of narrowed it down to where I might be. So
Good grief.
Yeah.
but when he came, they were very hesitant to even listen to him,
Ugh.
and because he wasn't my primary doctor. And they're like, "Who are you?" And I mean,
Yeah.
anybody in the spinal cord world will. I mean, all you need to do is Google Dr. Kirschbaum,
The
and
godfather of spinal cord
yeah,
injury
that's one of the
research.
leading authorities in the world.
Yeah.
And I had Mary Shea, who's an amazing occupational therapist, advocating for me too, for my skin and all these things. So, they I was combative. I wasn't moving. So, I started developing so I was there for 15 days,
Wow.
15 days that I don't remember.
Mm.
Yeah.
My skin was getting worse and worse. They didn't have me on any type of protective mattress. Um, because I'm not moving, you know, secretions are starting to build up. So I'm going into kind of acute respiratory failure,
Mm.
so, all these things. And you don't think about it at the time. I mean, I was completely out of it. But, for an SC, and at that time, their approach was, well, he has a chronic spinal cord injury. Why would we reach out to rehab? That's for acute injuries. But
Really?
they were contacting urology, they were contacting infectious disease. So they're consulting with all of these other services to address my needs, but they're not reaching out to spinal cord injury medicine or physiatry to address my spinal cord injury needs. And
Wow.
if I had come in with a history of multiple heart attacks, high blood pressure on all these medications, that's that yeah, that I would for sure be, they'd be consulting cardiology. So, I don't know why, they should use the same approach for people with spinal cord injury because, what went from, I mean, I had hyponatremia, I
Uh-huh.
had UTI. So by the time at the end of my 15-day hospital stay, I had a stage 4 pressure injury. And I was, you know, on oxygen, doing nebulizer treatments, all of these things to address my acute respiratory illness, the failure. And, they were talking about transferring me to a nursing home or some sort of subacute. And,
Wow.
we can't transfer them to Kessler. That's only for newly injured people. And thank goodness I had,
Oh,
people advocating for me saying that's absolutely not true. Submit the paperwork, we will arrange it. And
Hmm.
up until
wow.
up until that day and into the evening, I wasn't sure I was going to go to Kessler. But finally I was transferred to Kessler. And thankfully I went then to a place where people knew what to do. And it was amazing, and even in my mind, a simple with the cough and the respiratory secretions, a simple quad cough could have done
Mm,
wonders for me.
Right.
Up and giving me an assisted cough. There's something called a cough assist machine or a
sure.
coughator that can help people with spinal cord injury cough. So, just some of the simple things that a clinician knowing, whoa, this is a person with spinal cord injury. They have difficulty clearing secretions. We have to be creative
Hmm.
helping them clear their secretions with assistance, whether that be assisted cough, a cougholator, not just letting
Sure.
me sit there and slapping a mask on me and hope
Right.
for the best, right?
Hmm.
And then again, the pressure injury, which was so it went from 15-day hospital stay. I then was at Kessler for 3 months as I one,
Wow.
I
Wow. Mm,
remember very vividly Dr. Kirschblum, I'd been giving talks to the residents and the medical students about, spinal cord injury and, patients with spinal cord injury. And just remembering vividly the challenges during the acute rehab and I felt like I was back there. I was back
Yeah.
at the point. You know,
Hmm.
blood
yeah.
pressure when I sat up, for
Yeah.
that first week at Kessler, I was being pushed around in a chair, a
Yeah.
in space chair, so in case I started passing out, building up enough strength to finally get back into my manual chair, which just seemed like, oh my God,
Yeah.
never.
Well,
And even just like being seen by a neuropsychologist scared the crap out of me. It's like, "Oh my god, my brain." Well,
yeah.
Swiss cheese.
Yeah. Well, I have to tell you, as someone who works in the building, I get a readout of the census and who's around, and oftentimes we've had a couple people who are well known, and they come in and they have like a surname. We give them like a fake name, and when I saw Trevor Dyson Hudson, I thought, who picked that one out? Who's the movie star that picked that one out? And then I went down to the room with my sidekick Yokin, and wow, it was an eye opener for me, and I did not know the entire story, Trevor. Wow, that is quite a tale. So it sounds as if you went
Yeah.
in because of a UTI and you came out with a really bad pressure wound, and and you went from soup to nuts while you were there with all other
Yeah. Oh, I mean, really,
ancillary issues.
mental status. I have a greater respect for mental illness and periods of psychosis because
Wow.
I was living some very vivid, weird dreams,
Wow.
and the
Wow.
paranoia that came with that of people who I knew or
Wow.
loved. I mean, fearing, that my girlfriend was, dead or on the run because nefarious
Wow.
powers had taken over the
Oh,
government and people.
And it all had to do with the baclofen?
Yeah, yeah, I
a lot of
suspect it
it.
was,
Yeah.
I think a combination. I suspect it was the baclofen because, I did hyponatremia can cause some, the low blood sodium can cause
Yeah.
some delirium and things like that. But
Need your extra potentials.
yeah, yeah, exactly. You need that. Yeah, sodium's a good thing for brain activity. And but I was starting to improve and feel more human. They were treating the
Mhm.
hyponatremia. It
Yeah.
just I started to improve and then I started crashing. And
That's unbelievable.
yeah, and it kind of happened during a phone call, with
Wow.
my girlfriend,
Huh.
and I mean, even to the point that she took my phone away, but I was so convinced these things had happened that even my friend Mary, she came to just to convince me. She came to my apartment to look at my car. I thought I had killed somebody with my car.
Oh my
Uh,
goodness gracious.
No signs of any
uh,
damage or anything. It was just these weird dreams that I was so convinced. But it just speaks to, delirium and, but,
yeah. Yeah.
uh, and just the support. But I had incredible support. But
Yeah.
Well, I
still,
think that's an
they
important
still
point,
had
though.
to
But I
advocate.
think that's an important point is that you came out the other side, right?
Yeah,
And I've told my tales of my own recent experiences, and I think that's the epiphany for us is that we got through it. But does everybody go through this? Like, and who doesn't make it out? I've lost 3 friends this year, contemporaries, and one quad and 2 paras, not, and they all in the hospital
yeah.
for shoulder replacement surgery or things like that. And
Yeah.
it is, yeah.
I
And
think that
so,
we really have to be careful because, you know, if somebody with spinal cord injury, so you go into the emergency room, you have a urinary emergency department, you have a bad urinary tract infection, you get admitted. The thing is, you're now confined into a bed, right? You're not
uh
mobile. You're not
right,
doing these things, and we are so borderline when it comes to things like respiratory illnesses. So
mhm,
Yeah.
just, coming down with the flu or something like that can put you at risk for pneumonia. So
Right.
by
yeah,
by being
yeah,
confined to bed, by not being with people who, are thinking, well, how can this guy has an impaired cough? Uh,
right.
what can we do to help him
Yeah.
clear the secretions? I mean, it was amazing.
So, Trevor, we've been discussing something for a while, Barry and I, and we've introduced John to the concept of a code ER, spinal cord ER, code spinal cord, or something called SCI. Because again, it's not that we don't have the capacity; it's just that they've not been conditioned to it. They haven't been trained to do it.
Right.
And that's I don't know, Barry. You want to pick it up here? You've been kind of quiet up there, North.
Well, I always yeah, they call me I'm North. By the way, it's 100 and something degrees here today. We're almost
Also,
so
Oh
oh
yeah,
yeah,
we're
wow.
happy. Um, I was thinking about one of the things that it's been troubling me a lot, and it's around what you were saying, Trevor, is the inability to communicate when we really need to, because we're
yeah,
pretty good advocates. Like this, we can handle it, and if we need something, we'll also push for it. But the second that's impaired, like it happened with you, we're in trouble
yeah,
because they don't know what to do. And if you're not even with somebody who's a hard, dyed in the wool guardian, they won't know what to say. And so,
Hmm.
and I use examples of there was a guy up here. He was a pioneer in independent living with ventilator quads, and he was just it was a place called Nucleus. Nucleus was a
Hmm.
first independent home in Toronto, and then the Nucleus too. The guy was I can't get his name, but he was just something else. The C1 C2
wow,
quad. He did so much, and I because I can't say his name, that's okay. So what happened was
Right.
He ended up getting a bowel obstruction. Okay. Got severe AD. Goes to the hospital. He can't speak. He's stroking. He can't say what he needs to do. He dies. And if someone just, and we have a rule here, if it's AD, chances are it's pee or poo, right? It's one of the two that you got to go to first to check it all out. And there was an example, but I want to use, I might have talked about this before, guys, and maybe I didn't because I keep talking about a lot. It was the story of a gentleman, an older fella in Montreal, or a suburb of Montreal, chronic spinal cord injury, quad, went in with pneumonia, okay, to a tertiary hospital. And there was a backup. He was in a gurney for a few days, not even in his own room. And his partner kept on saying he needs to be turned.
Yeah.
He didn't turn. Ends up getting a category 4 pressure ulcer, gets sepsis.
No, good grief.
And so he's going through all that. He's still there. And then you add another unfortunate thing is in Canada, we have a program called MAID. And it's an acronym for assisted suicide, medical assisted suicide. And he opted for it. So here's a guy going in with pneumonia to a hospital and ends up choosing, which is more or less what could have happened to you, Trevor, even if you didn't have a choice.
Yeah.
Or the hospital itself, the place you're going to that's supposed to help us, is the worst thing you could possibly do in the way this thing played out. And I'm just thinking, and then the one thing I know in Canada is that the cycle for a medical training for medical doctors, it's 6 hours to get a spinal cord injury. And how many years of education?
6 hours.
6 hours. So somewhere back in the confines of the mind, they got to go back and find, what do I know? And I use an example. As you guys know, when we go in for something, we have to go to an ER because I can't transfer into a regular urgent care facility or walk in or anything like that. So I always get it. I go in with some symptoms. I'm dysreflexic. Something's wrong. Turns out I had a broken rib. Example, right? And I'm trying to explain it to the doctor. And I said, you know what AD is? And he explained, I don't know, dyslexia. Oh yeah. And then it's like you start walking through. You might want to explain that again. Yeah. Okay. Let's go through it again. But again, I'm communicating. I'm talking. I'm advocating. I'm not letting them push me back. What if we don't have a voice?
If you don't have a voice, guys,
that
Barry, you've hit the nail on the head for me, and I can say this now because I survived. But I was in alone. I went into the ER with a damn 2 rucksacks full of shit because I didn't know what I had to take. Right? I didn't get out for 9 days. I didn't get out of the hallway for 4. Like,
jeez.
So, and again, so you get tied up to all these tubes and again, they're not treating you as a neurogenic person. They're treating you as an invalid. Almost, to be honest with you, I shared a story of a friend of mine, Charlene, out in the West. If they actually treat you like indigent sometimes. They do. First thing, what's going on here? Do you have a place? You can't get out of your chair, by the way, to ER. You can't get out to like alleviate your pressure or whatever. You have to stay until you're going through the whole thing. Well, that could take, hours, not sometimes. And what do? A lot of the times, unfortunately, it's attrition. They wait till you leave. Like, and what is that? Like but at the same time, you're saying you go in and you're damned. You're damned if you do it and you're damned if you don't.
What's amazing about all of this is that, and knock on wood, I don't have any horror stories, and I hope not to have any, but it's not as if, you 3 gentlemen don't have, we talked about in the beginning, almost 100 and some odd years of being injured and being in the fight and being in the arena. You guys know what you need and what your bodies need. And Trevor's a doctor, and Sasha, you're a professor, and Barry, you're a brilliant guy as well. And if, what about like my neighbor who might have a spinal cord injury that's just, a 20-year-old kid that was surfing and that doesn't know, and the mother that doesn't know, and because they had a 4-week stay at a rehab hospital, and now all of a sudden, how do they advocate for themselves? I mean, do they just disappear into the system? What's the alternative for someone like that? It's scary hearing these stories.
Yeah, it is.
I mean, all we can do is try to advocate and educate and advocate, right? And just keep raising awareness.
Hmm.
I think something was that Sasha you brought up. I mean, it's the perception, right, of worth. And you look at somebody with spinal cord injury, and an outsider might be, wow, what is, there's a judgment, right? This is not a young person. This person with paralysis.
Right.
Life is that. I mean, it's the same look elderly people get. I remember when my
Right.
dad was in the hospital and had heart surgery, and he went in this vibrant guy and he came out looking like death warmed over. And just
Mm.
how the people treated him was so
Sure.
different.
Yeah.
Right. And so I just think it's, unfortunately, sometimes people put worth on patients, right? And
Well, I could tell you, I've already said this in public, so I'll say it again. When I was in the hospital, I first had to go through colostomy and things of this nature for decubitus, stage 4, like yourself, lots of things. But when I then was diagnosed with pancreatic cancer tumors, and when I went into the oncology, man, it was like going from I was think I've quoted this saying a truck stop in the past, like a truck stop to like a nice hotel, because everybody's greeted because it's a cancer condition. You're kind of sad. There's a lot of money in it. Wound care? Are you kidding me? Wound
Right.
care is the bottom of the barrel.
yeah.
Like
Yeah.
the nurses are all complaining, and they're like, and you wish that you could like write down everything they're saying and then somehow help them help. Nobody. I mean, it's you're cut off. Kind of like that's the interesting thing. It goes back to what we're talking about, the continuum of care, right?
Hmm.
Like wound care is a lot, but somehow it's treated like we'll see you next week. Yes, there's time, but is there things you can do between that time? By the way, you just want me lying around watching TV for a week?
Yeah.
Like what?
Right.
Like what? You all just I don't know. There's no plan anymore,
Yeah. Yeah.
and it's a shame. It really
Like
is.
you
And
said before, Sasha, about, the three of us had been kicking around the idea of how to sort of educate, folks. I was almost thinking like we could call it CSI, SCI, like something like that. But if we could go around the horn,
Sure.
if you could each maybe pinpoint at least one thing that if you could get into the emergency room and tell either the attending physicians there or the nurses or whoever's in there, like what are the top few things that they should be looking for, or that they should know when someone like one of the four of us winds up in one of their gurneys.
Oh, I want to jump on that one right away. It's
Yeah.
autonomic dysreflexia. It's understanding that, because that's a kind of an all-encompassing, this is what we should be looking for if
Hmm.
someone can't communicate it. And I know why I'm bringing that up is that there's been Praxis, for example, in Canada, put together a chart that they want to have in every ER that explains it. I know Chris Renee Reed, they have a card, I think, that goes in your wallet
Uh-huh.
potentially. I'm experimenting or talking to somebody up here with the a tech company that we're think of something in a smartwatch or a medical alert that could have it, and they could scan it and have your whole medical history there.
Yeah.
I mean,
Yeah.
we can, but my point is, AD, I think, is the one thing they need to have something to say, okay, something's going on. Here's
Yeah.
an example. I want to give just an example. Sasha, you've heard the story from our friend who has a son who had to go to the ER. The
Hmm.
son was getting dysreflexic. He was going through some AD, put it off. Something was wrong. He went to the hospital. At the end of the day, his father, who has an experience around his guardian as well, around the hospital, came there and realized they're about to treat him for a potential heart attack because he was spiking. He had a clogged catheter.
Yeah.
You can see where this could go.
Mhm.
Somebody that would know at least enough to say, you got to check these things first, and then that could
Right.
really set down. And that's
Yeah.
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 It's
Barry, if you could, for some folks that may not know what AD is, can you just sort of, in a nutshell, tell us what it is, how it manifests itself, and what are some of the incidences that cause all of us to
you want
unfortunately go into
you,
it?
you want the lay version, because that's all I'll give you.
Yeah, give
Autonomic
me the
fine.
Reader's
dysreflection.
Digest.
I
Sorry,
always
I'll
say
eat.
it's our body's way of you're dealing with your sympathetic and non-sympathetic nervous system, but your body's way of telling you something's wrong where you don't have that neurological connection of feeling, for example, pain. Any
Right.
type of pain, your blood pressure will spike and you turn into some sweats. If it's severe enough, you could stroke. And I always say to somebody, if you've got a burn going on, like good old UTI does it. A twisted bowel will do it. Bowel obstruction will do it. Pressure ulcer is a big one. That it's telling your body is something wrong, and
Yeah.
then you kind of work it backwards. You know what I can't stand is when you get in, you can't figure what it is.
Mm.
That makes me
Yeah.
nuts.
Yeah.
Yeah.
Mhm.
And it could be
Yeah.
Well,
simple. It
John,
can,
John, to get more technical, just to throw a little bit of spice onto this,
Yeah.
the autonomic dysreflexia causes blood pressure spikes for sure, but what defines autonomic dysreflexia is a concurrent bradycardia. So your blood pressure, while it's spiking, your blood pressure, well, excuse me, your heart rate reflexively, this is a normal response, drops.
Right.
But in a spinal cord injury, your brain doesn't tell your spinal cord to chill out, everything's fine. So what happens is your blood pressure remains high. Okay, but your heart rate keeps going lower, and that's when you can stroke out because that's when you lose the pressure.
Yeah.
Anyway, that's the dysphoric feeling also
mm,
of autonomic
and it's
dysreflexia.
Hmm.
Is that
generally seen
I
in
called it
people.
my danger Will Robinson. That was
Yeah.
back in the 60s.
Danger,
Yeah.
danger.
Yeah, it's generally seen in people with injuries above T6
Correct.
because that's the parasympathetic and sympathetic ganglia are located
Yep.
there. So with higher level injuries, as Sasha saying, it's kind of a fight or flight response. Your body's saying
Mhm.
something's wrong. So
Hmm.
so your blood pressure
Hmm.
goes up. And it doesn't need to be pain. It could be some people can
That's
have
right.
it during
Non-noxious
sex.
stimulus can
It
also
can
do.
be,
Yeah.
just a strong sensation, and it can be subtle signs of sweating, things like that. But yeah, it's in your
Right.
fight or flight system just kind of kicks in and
Hmm.
doesn't counteract it like it would if
Right.
in somebody who has an injury below T6 because
Right.
Hmm.
they have mechanisms in place to dissipate that blood pressure buildup, or
Right.
somebody who's able-bodied.
Right.
So,
How about you, Trevor? Barry hit on AD. What would be one thing? And you just told us about your experience.
yeah.
What is something? I guess maybe the deprivation of the medication that they were
Well, I mean,
depriving you.
it's so there's so many. So I guess I could be prepared.
Hit on a few of them.
Yeah,
Yeah,
no, so
knock them
I
out.
would just say, be prepared. I look at my phone and I see there are apps there. In fact, I mentioned my friend, after this incident, she was going through with me and just showing me how to enter information into this thing.
Hmm.
So I use an iPhone, and so I can enter all kinds of medical information in there. You know, prone to autonomic dysreflexia.
Mhm.
Medications, all these things, emergency contacts, other contacts. So just
And this is an app that you have at
yeah,
the
yeah. There's
uh,
I think it's one of the emergency apps, and in fact, it's one of those things you can access without having the passcode to your phone. It
Wow.
will
oh,
even be you
Ah,
can
that's
even
good.
you can even share, like if you call dispatch, there's ahead of time, right? Because in my brain I wouldn't have been in a position to agree or disagree.
Right.
When you call the 911 dispatch, it shares that information with them. Now I
okay.
don't
Hmm.
know what they have in place at their end, but the things are in place to share all of this medical information with the dispatch, with the paramedics, with the emergency room. And I guess the thing, I truly appreciate, educating ER docs and all that,
Mhm.
but they're dealing with so many things. I guess I would just don't be afraid to reach out to spinal cord colleagues. Look, I
Mhm.
got somebody with a spinal cord injury. What do I need to consider? Uh,
Right.
just like, if you were, as I go back to the cardiologist example or the infectious disease example, an emergency department doc would be got to get cardiology consult down here, because this guy, is on all these blood pressure medications, and I don't
Mhm.
know how to handle these. So, whereas with spinal cord injury, they don't give it a second thought. So, think about your rehab colleagues,
Mhm.
and just reach out to them because it
Right.
may be, it's great to raise awareness. And that's the other thing we're trying to do on a physician organizational level, reach out to
Right.
primary care doctors to raise awareness. But, in the interim, just raise awareness about reaching out for consultation.
How about you, Sasha? Do you have some? I'm sure you've got some ideas rolling around in your brain about maybe how we can, put like neon lights around these situations.
Yeah, that's a great question as far as how do we heighten our awareness. Like going back to the original question, which I'll first floor, is that I think also another thing that they're painfully unaware of is the fact that when you come into the ER, you're there on limited, like you need to be tended to, like somebody with a cardiac. As a matter of fact, I have a quick anecdote. When I was in the ER myself, vomiting and all this kind of stuff, I actually helped a guy probably live because he was a quadriplegic who was going through respiratory distress himself. And they were not tagging, and he was tagged. And so again, it's one of these things where how do you heighten this awareness? So I guess the first thing, and this is the catch 22 for all of us. If you have somebody going in with you, that's number one, the greatest thing. If you don't, like Trevor and myself, if you have a kind of a network, that's a really positive. But there's where I kind of like feel like, well, where are the rest of the people?
Mhm.
And that's where, I think that us and our platforms were able to discuss this, but we don't necessarily have solutions. And like you said, Trevor, bringing awareness to this in forums and having, other people like Dr. Kurzweil, whatever, they start echoing and resonating these things, it may start to take form. Having said that, we've been doing this for a long time, guys.
Yeah.
Hmm.
And I'm waiting to see what's going to nudge the needle because of the way funding is now, the way things are being cut, and it's just not, it's not enticing.
Hmm.
Right.
Is this something that almost you need to get down to grassroots where it gets into medical schools and curriculum and we bang that drum where we start to go to these major universities and these where all these grants are going and say, hey, listen, we have to take this a lot more serious. Like you mentioned, 6 hours or something. I forget who was it that mentioned it was 6 hours of the curriculum, but
I did.
yeah, I mean, what are we talking about? That's like a drop in the bucket. We need to
Yeah.
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 really, get some eyes and
It
ears on this
well,
situation.
it's
Well,
all
so,
the
so
above. That's Go
yeah.
ahead.
No, go ahead, Barry.
Well, I was gonna say, I think it was off air. Trevor was talking about this. It's like you just got to keep on going and advocating. Again, all right. Here's my bitch. Here's my bitch. Okay. Every time we do this, we call it Barry's bitch. Okay.
Go
So
for it. The
and
BB.
here's my bitch. They are just shortening the rehab to such a point where we're not connected to any what I call organic networks, where just by hanging around a rehab facility for so many months, you naturally connect with people, connect with contacts, you get comfortable with networks. They're sending people out there still in collars and halos, for God's sake, back into the
Mm,
community. They don't even have friends in chairs. That's my problem.
Yeah.
They're not connected. So, I mean, the work that Kessler's trying to get going, and you talk, Sasha, what they're doing in British Columbia is anything outside that will increase navigation and helping people. There are good resources out there. That part I know, but they're so disconnected and sitting
Right.
somewhere and no one's accessing them because they don't know
yeah.
how to.
Well,
Sorry,
okay, so
that's
here's a small plug, and Barry, you're aware of this, and this gentleman, I'll introduce you to this app if you haven't heard it. It's called Spinally, Spine Ally, however you wish to pronounce it. It's done by
Okay.
Aaron Phillips, developing up in Canada. Long story short, and Kim Anderson, this guy got off the phone with him just a little while ago. I really believe that we need an app, not any kind of computers and not centers of excellence for people to upload their data individually from their iPhones. Now, pie in the sky, Sasha, bullshit. They've already got a prototype unleashed. They've already been using it for a year. They've already got a lot of preliminary data. The problem is that there's a lot of people who want to wear hats, right? You want to take ownership of these kinds of things. That's where Kim and I are working with him. We'll see how this goes. And, this is the first time people heard it online, is that we are going to be pushing for organizations like the Reeve and Nielsen Foundation to give us money to do this because it's way overdue. Like,
Yeah.
why haven't we had a centralization process way before this,
Hmm.
because centers of excellence, of which there are 18 across the United States, represent our estimated numbers, right?
Yeah.
Well, those estimated numbers are based on 15 years ago, from what I understand, right? That so there's another big quagmire is, well, if we want to represent ourselves and we say we're 18,000 people, but really we're 25,000 to even 30,000 a year that get injured. That's a big difference when you go ask for go ask for money from politicians, because you have a bigger health burden, which we already do.
Right.
Only second to ALS is quadriplegia
Yeah.
in World Health Organization.
Right.
Did you
Well,
know
And
that?
Sasha, what information would you be able to upload into that app? What would that entail?
Well, right now it's mostly personalized stuff, and it's also it's de-identified also, which is wonderful. They don't own the data. They all have it in a repository. And I went over those algorithms today. It was amazing. I didn't know this stuff existed.
Mhm.
But what you could do is, once it's out there, so it's got stuff like how you feeling today, just kind of colloquial stuff, but resources, websites, all kinds of things that are drop down menus where you don't need to leave the website, excuse me, the
Mhm.
app. Moreover, it's anyway. I'm pushing this much too much because, boy, he's still got to develop it. But I think that when you hear about this, and I'm going to be plugging it pretty soon, follow along, because I think this is the way to go, because I don't think we're going to wait for somebody else to say what we're going to do with the data.
It's
And Barry, this
exciting.
has to do, I think, with your NASCIC work, doesn't it? You're working with, I believe it's Abel, on something
On the
AI
it's
component of some.
AI side of it, but not Spinal. But I am. It's
Mhm.
everybody's kind of floating around the same. What's happening right now? Just a bit of a clarification
Sure,
to your
please.
point, because that's where the app idea comes from. Is Nielsen funded NASCAR to put together what's called an SCI powered network. That's more on the other
Yeah,
side of looking at all the resources that are out there. How do we organize them, and how do we basically give them the good housekeeping badge to say that this is
mhm.
good information, so
mm,
that people that are go looking for it don't run down a Google rabbit hole, or now
Gotcha.
even AI. Because so the AI side of it is actually trying to create the ultimate SCI chatbot,
Hmm.
that
Thank God.
it's
Okay.
it's good stuff in, good stuff out, which could be it'll be universal and publicly used, and could be
Yeah.
Uh-huh.
used on Spinelli and anything else. But to
Hmm.
your point, where the app idea, circling back to what you're saying, Sasha,
Uh-huh.
arthritis has already been using it. They have a powered network, and they use the data, and they use it for it's for research. Really, what do we do? And they can pull this stuff up. And muscular sclerosis has one too,
Uh-huh.
where it's like a power network and an app that goes with it. What we don't have on the SCI side is this power networks and getting moved. They haven't settled on the platform and what the app would be. I'd love to see the two come together,
Sure.
but that's not there yet. But that's something you
Gotcha.
can advocate for, Sasha. I think that
Yeah,
would
I'd
really.
love to be a connection, because I just got I mean, I was actually surprised at how much he's done. He gave us the whole deck. He gave us the whole deck. I was really surprised, to be honest with you.
yeah.
Now,
I mean,
where it's going to go, and this is answering your question, Trevor, what, or maybe it was you, John, that asked about what can you put in. That's what we're going to be deciding, right? Put in your, for instance, I mean, one of the biggest problems we don't know about traumatic versus atraumatic spinal cord injury. Like, there's no network. Usually it's typically just traumatic. But what about atraumatic to still have the
yeah.
symptoms?
Yeah.
So again, it's a quagmire. You open up one thing, oh shoot, but they've got algorithms. I mean, I was just floored. Again, I'm not a software engineer, but I'm just floored by what they've been doing and how much, and they've invested a lot of money into this. And he keeps saying, I don't really have he was happy that Kim and I talked to him. And actually he had mentioned you, Barry, that you've been a very big supportive person in the whole thing. So,
Yeah.
anyway, just for foods for thought with regarding to how do we centralize this stuff.
Right. Well, and you raised non-traumatic injuries, Sasha. I mean, they're not counted in the model systems,
Mhm.
right? So, and there's likely much more than of those, and those
Yeah.
individuals often aren't seeing rehab doctors. They're being treated by a neurologist. But they're dealing with all these secondary medical complications, just like somebody
Mhm.
with a traumatic spinal cord injury.
Right.
Hmm. Hmm. Well, gentlemen, at the beginning of our conversation, I made a half-hearted joke about we were adding the fourth Beatle to today's podcast, and I think we've come up on 45 minutes now. I think what we'll need to do is get the band back together again, dun-dun-dunch,
Happy to
and
join.
Sounds
Yeah,
good.
we'll have to hit on
Fun.
some other topics. We'd absolutely love to have Dr. Trevor join us again. I think today we really did a service to shine a light on what is not known in emergency rooms and in hospitals and whatnot, and try to shed a light onto that. And hopefully in the future, I know some topics such as aging with spinal cord injuries, something that we all are facing right now. We're not spring chickens any longer. And that's something that we could put that ball on a tee and hit it down the fairway. And there's plenty of other topics I know that we are going to want to riff about. And so why don't we go around the horn, some final thoughts. First of all, Dr. Trevor, if you had any final thoughts on today's discussion you wanted to get off your chest.
Yeah, no, I mean, I just think we keep advocating, we keep educating, we can't stop. That's the take home message. It can happen to any of us, and we support. You're not alone. I think that's the important thing. There are resources out there. Don't be if you are alone, don't be afraid to reach out to some of these organizations that are out there, because they'll welcome
Yeah,
you.
I think that's good. How about you, Barry?
I like the idea. Maybe it's for another day, but we should all think about writing a letter to our former self. And and the things that we know now that could have kept us from getting into the hospital and
Right.
doing some steps, at least being ready for such a visit. I know I'm not, and I get worried just by hearing these stories, and I think we need to be proactive in figuring these things out, unfortunately, because
Mhm.
the best advocates for us will be only ourselves, I think, in this case.
Mhm.
No doubt. Sasha, take us home.
Oh, in Russian, be prepared. Russian, be prepared. Um,
With
it's
vodka.
yeah. I mean, it is a colloquialism, but honestly, like I was saying, if you don't have a team, like necessarily, if you don't have a companion, you still have to have plans. And I know that sucks, but don't let it go, because when we were injured, we didn't have Christopher Reeve, we didn't have these societies. We
Yeah.
managed though, but it's because we managed from within. Now people have to manage from outside, which
Mhm.
is
Right.
really kind of the conundrum, because now instead of being in the pool, they're being thrown out, and then somehow they still have to, be somehow connected to the pool. And so
Right.
that's a difficult thing, and be
Mhm.
prepared. That's what, and reach out and make connections.
Words to live by. Words to live by. Again, thank you, gentlemen, on behalf of for Barry Munro and Sasha Rabchevsky and the esteemed Dr. Trevor Dyson Hudson. I'm John McAleavey. We want to thank you for joining us, and be on the lookout for future episodes we're going to bring Dr. Trevor back. We'll also have some other guests, and we hope that you'll hang around with us. And so thank you for being here for this latest episode of the Three Men and an SCI podcast.